Thank you so much, Christina, and especially Ron, for setting this up and bringing people together, families, doctors, researchers from all over the world. And I think it's really a very touching and also very successful story you shared with us. So thank you for making that possible. And I'm really happy to be here and to meet you in person after I've met some of you already on Zoom or via email or through MRIs and genetic information. So it's for us something we are very grateful to see and hear about your problems. So there are some disclosures now, and I think it's a good thing because it shows that things are moving. Pharma is discovering leukodystrophies, and we have some clinical trials going on, and I hope very much that that will also be the case for age, not in a too distant future. Let me share how it all began, because it began 22 years ago when I was a junior doctor in my second year of training as a pediatrician and child neurologist. And I met Sophie, who was admitted to the ward for investigations because she didn't have a diagnosis. And she was 8 years at the time. She had an MRI which looked like hypomyelination, but she was a girl, so it couldn't be Pelletier-Merzbacher disease. Moreover, she was able to walk with a retro walker, but she was able to walk. She didn't have nystagmus, and she didn't have any teeth at that time. So that was of course, a bit of a strange combination. We didn't find any information about that combination, and she underwent a lot of procedures to find the diagnosis. She was a very cute and also very determined young lady. So she visited me many years after when I was already in Amsterdam. So I saw her before she unfortunately passed away 2 or 3 years later. And 2 years later, I saw another girl, 4 years old. Actually, I didn't saw her. I saw her MRI on the MRI meeting. And then I heard from because I did my ICU, pediatric ICU rotation at that time. So I didn't see the child on the ward, and I asked my colleagues, how is she doing? What is it for a child? And they said, well, she walks and talks and is a very, very friendly and very happy young child. And I asked anything special with her teeth, and they said, well, she has no front teeth. So I looked at both MRIs and thought, must be the same thing. And then I started to ask around, and I think within a year we found 2 more patients with the same combination of symptoms. And at that time I thought it can't be so rare, because if I'm be able to find the 4 patients in 3 years time, as someone who has otherwise not much experience in this field, there must be more patients. And in the end, it was true. And it's one of the most common hypomyelinating disorders. And look where we are now. So it's a story which shows that really cooperation is the key, because there were other doctors since who sent a lot of patients and data. So that made it possible for Geneviève and Adeline and I to have that first data collection on more than 100 patients. And I really hope you reach your number, and I will chase the European patients to get registered for your registry. So collaboration between families and doctors and researchers is really the key for those rare disorders. So in Amsterdam, we have 3 child neurologists working on leukodystrophies. Maya van der Knaap founded our center. Mark Engelen sits here in the back and works on especially XALD, AMN. And my focus is hypomyelination, 4H and Pelizaeus-Merzbacher disease, but also metachromatic leukodystrophy. And that's actually a good thing because you can really learn also from other leukodystrophies. And I will therefore compare 4H and MLD a little bit with each other. The setting in the Netherlands is, we are a very small country, so 17 million people and a very small area compared to the US. So we see more or less all Dutch patients. Children, adult patients, they visit, the frequency of visits depends on age. We also have a pediatric endocrinologist and an adult endocrinologist with experience in the disease, and also the rehabilitation physicians take care of those kids. And we are part of also a European reference network, rare neurological disorders, and there are also really efforts for treatment of specific variants, NS1 trials, and so on. So there's a lot going on, and that is, of course, also something which is very gratifying for us. So the current research we do in Amsterdam regarding 4H is on biomarkers, MRI myelin quantification, epilepsy, and the atypical forms. And we have a translational research project with Vivi Heine and Stephanie Dofes and Lisa Koch, where we look at myelinating co-cultures of patient-derived iPSCs and have made cerebellar organoids. And I won't talk about that today. What makes 4H a challenge? It's a relatively new disease. So the first description of unrelated patients with this combination was in 2005. And the genes identified in 2011. And compare that with MLD. The first patient was described in 1910. Metabolic basis identified in 64 and the genetic defect found in 91. And the same is true for Pelizaeus-Merzbacher disease. So that's a huge extra time those disorders had. Then 4H is ultra rare, although I think it's about as rare or frequent as Pelizaeus-Merzbacher disease. If you look at the POLR3 related disorders, you have different disorders like the basal ganglia variant, the spastic ataxia, the very severe Wiedemann-Rautenstrauch syndrome, which are other disorders than the typical 4H leukodystrophy. MLD, metachromatic leukodystrophy, has in the beginning a normal development, and then children or adults lose things. And Pelizaeus-Merzbacher, we know patients with very different severities, but it's basically the same disease. And 4H has also the classical disease has a broad clinical spectrum. So what we can learn from other leukodystrophies? Just a little bit of recap. 4H is the classical form of 4H is a hypomyelinating disease, which means that the brain, which actually matures during the first 2 years, doesn't do that. So when you look at an MRI of a child with a 4H, it looks very much like the MRI of a child which has just been born, in contrast to a 4-year-old child with a normal myelination. That means there is something problematic with the white matter right from the beginning. And that's different from, for example, MLD, where you have a normal white matter, which then starts to degrade. MLD, we know 3 clinical presentations, early to late, until late adult age, actually. And as a rule, you say the earlier the onset, the more rapid the progression, and the more prominent are motor symptoms. And although, and we know also that it depends a little bit on the severity of the protein defect in metachromatic leukodystrophy. But what is actually interesting, although the disease has been known for such a long time, just I think in the last 5 years or so, the Tübingen colleagues and other groups found that there is really a group of patients with late onset who have a cognitive presentation, and they can have a stable motor function for decades. So although we know the disease for a long time, it's not that we know everything about it. And there's still a lot to discover, and that's important, this kind of information when you do clinical trials, because endpoints is often motor function. But when we know that motor function will be preserved for 10 or 20 years, that's not a good endpoint for a clinical trial. I think I can, when I think of 4H and the patients I know, and it will be very interesting whether the registry data actually support this. You can actually make I just leave out the Wiedemann-Rautenstrauch syndrome for a moment, 3 large groups, the basal ganglia disease, which is actually probably relatively frequent, I think, 4H leukodystrophy and the spastic ataxia. You can have a different kind of ages of onset and severity. In the basal ganglia disease, the very severe neonatal onset, but you also have a childhood onset, which looks a little bit different and has a much more protracted course. So you could actually relate that regarding classifications to MLD or also Krabbe disease. And the same is true for 4H leukodystrophy. And we have a group of children who do not have hypomyelination on the MRI. Sure, please. Yes, sure. I can also share the slides as PDF later on if you're interested. So. No, please do. And the spastic ataxia patients have a very specific variants in polar3A and have a later onset. And it's, I think, important to have in mind those different kinds of presentations, and also sometimes specific genetic variants, because that might give again another entrance for treatment design. And just to show you the difference in MRI, that's a patient with a typical 4H, and you see the hypomyelination, the myelin defect, if you compare it to a normal child. 6 years later, it looks exactly the same. And that's a child with the early onset MLD, and Daphne made that picture. She sits also here, and you see that within 4 months, the white matter has been completely changed through the disease. And that makes 4H, if you look at the MRI as a biomarker, a little bit tricky. We know that the clinical presentation in different hypomyelinating leukodystrophies can be very different, although the MRIs look very much the same. That's actually a child with the 4H. At that time, that little boy was able to walk with some balance problems, but otherwise no motor issues. But when you look at the group of 4H patients, you do see that depending on the degree of myelination, the disease is more severe if you have less myelin. And also when you get older, you lose brain tissue, especially white matter, and that also correlates with increasing severity and disease severity. We look at quantifying myelin with MRI, and we look at different technical parameters. And what's quite striking, although you see such a clear difference between hypomyelination and normal MRI, when we look at those quantitative MRI parameters, 4H or hypomyelinating disorders are the most normal of all leukodystrophies. And that's also something we need to understand if we want to design clinical trials. And I would like to show you a spectroscopy where we measure certain chemicals in the brain and you see that looks very much like a normal brain. And when you compare that to MLD, for example, you see that that looks really different. For example, this NAA peak has been completely lost. Body fluid biomarkers, we don't have good body fluid biomarkers, whereas we do have them in MLD. We looked at a neurofilament light chain. That's a protein which is released by the nerve fibers when they are damaged. It's not disease specific, so also after trauma you can get a neurofilament light chain in your blood and in your CSF. But you also have to realize that if many neurons are already gone, your NFL gets low again. So in very severely affected patients, it can be that the NFL is quite normal when they are very stable at that stage. But Shanice Verepot, another PhD student, showed for MLD that actually, a bit contrary to our first expectations when we looked at only a few patients, it's a useful biomarker, especially in the young patients, and especially just before the deterioration starts. And when we looked at for age, I was at first a little bit disappointed because it was relatively normal. But when you look closer, you do see that it is elevated compared to controls. I didn't do the exact analysis, but just from knowing the patients, I did that test. It's more elevated in patients with more severe presentation. So I think that this is a potential biomarker. I shared those data with Adeline van der Ver for the grants. So I hope we will see more about that. So I think we can learn a lot from other leukodystrophies and also learn a lot from the fact that we really got into detail, for example, in MLD with those very circumscribed special presentations quite late. We should do it really well now. And we need also good biomarkers because that's all important for future clinical trials. We need a good and meaningful outcome measures, but it shouldn't be too complicated to collect all those data, because if you collect a huge amount of scales and scores, I'm not so sure whether you would go for years with your child 4 times a year to a very extensive testing battery. So we need to look for good scores, which are also robust, which you might also do remotely, certainly in times of a pandemic. And I hope that we will all together manage that in the next years. So thank you all for helping us with this work, and also all the doctors who sent a lot of scans and patient information and skin biopsies and so on. So thank you, and please ask your questions. Okay, thank you. The question is, what's the difference between hypomyelinating and demyelinating leukodystrophy? In hypomyelination, you don't make myelin, and that's from the beginning, so from birth. So myelin is never properly formed. In demyelinating leukodystrophy, you have a normal myelin development until a certain stage when the disease starts, and then the myelin which is there is degraded quite rapidly. So that's what we call demyelination. Sure. Oh, thank you. So the question is whether the myelin the body does make, or the brain does make, whether that's of a good quality. We don't know. And that's something we would like to find out with those extra new MRI techniques. And that's also something I hope we could explain the difference between some patients, although the MRIs look so very much alike. So perhaps that helps us. Yeah, thank you. So the question is whether when two patients have the same MRI, whether they present similar. When I see a patient, no, actually no, I have to say the short answer is no. There is a longer answer, but the short answer is no. When I see a MRI with hypomyelination, I never know whether the patient is walking into my room or is coming into a wheelchair. And has also other severe motor problems like with hand function. So I can't see that well on a simple MRI. And that's a question which we've asked ourselves already for a long time, and we still didn't come up with a good answer. Yeah. 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 Yes, we have also severe polar 3B cases. As a group, the polar 3B cases are milder, but within the group of polar 3B cases, we also have severe ones. Yeah, that's one thing we are working on, and also I think your grant application is about. It's an important question, and we all would like to have more measures to better predict disease cause. Oh yes, excuse me, sorry. So the question was that whether there are good measures to predict deterioration of patients and severity. And no, there are no good measures, but many people are working on finding more information and more informative measures for that question. Yeah.
I don't think I've ever seen much data before about NFL. Could you share a bit about the usefulness of it?
Yeah, yeah. I think that those data are actually at the moment not enough to understand the use of the potential use of NFL. I think we need more. We need more data points, and we need a good correlation with the severity and the stage of the disease. But I think when I look at that, and when I remember our experience with MLD, where I was also very skeptical at the beginning that it might be useful. The NFL gives us information about the nerve fiber and the nerve cell, but we would also like to have a biomarker for myelin, for example. So how much myelin, how good is the myelin? And NFL is a very indirect biomarker. So I hope we will also find at some point a direct biomarker for myelin.
The differences in the administration of spectroscopy versus MLD versus 4A. Relatively total changes, it seems that maybe the total increase is a little bit lower. So I'm wondering, have you looked at longitudinal data for the change
Yeah. So the question was about the MR spectroscopy, where we measure those chemical substances in the brain, certain chemical substances in the brain. Actually, we have a lot of longitudinal data on 4H and other hypomyelinating disorders, and I would love to look at them, but I need someone to do that. And that's still actually sleeping in our data collection. Yeah. So what we hypothesized was whether the NAA is very slowly decreasing. One of the problems why we just can't pull out data and look at them, and after 2 weeks we have the answer, is that when you look at a very long time frame, you have usually your hospital buys another and perhaps another MRI scan, and you always need to calibrate those data and to find a factor to compare them well. And that sounds a bit basic, but that's how life is. You never can do the same use the same MRI for a period of 10 or 20 years, because there will be better MRI scans, and so that's one of the really daily life issues we deal with. Yeah. So the question was about the adult onset, and that's quite variable. We see patients with balance problems or late onset tremor, or also mild movement disorder, but we also see patients with a psychiatric presentation, like a psychosis, or very prominent behavioral problems, and almost without or only very mild motor issues. Very behavioral, yeah. Yeah. So the question is about remyelination, whether there are studies on remyelination, not for hypomyelinating disorders yet. There will be some, but not yet, and not for 4H at the moment. I'm afraid. Mm-hmm. Yes, you're right. Yes, yes, yes. So the question was about volume loss. You are completely right that also normal people have a volume loss of the brain that sets in at around age 30. But in 4H it's much earlier and more prominent. So you do see the difference. Mm-hmm.
We're not the same, I guess, or sub 4H and 4H sort of tie together, and you mentioned sort of separately.
Yeah, thank you. So the question is about the different disorders or presentations, and you're right, I should have explained it better. So when we started with what is 4H, we came from those children who had this MRI scan with a lack of myelin, and also a loss of volume of the cerebellum, the small brain. So that was what we knew, and the combination with the teeth, and in the older children, the puberty delay. So that was what we knew as 4H syndrome. Then the gene was found, or the genes leading to 4H syndrome. And then we found more patients with a more severe, milder disease. But then nowadays we look differently with genetic testing. So at that time, when we found the disease, so the disease gene in 2011, we did often, we saw that patient, we thought it could be 4H, we looked at the POLR3 genes, we found the variants, and we had another patient. Nowadays, you often do it's the other way around. You have a patient with a neurological disease, you don't know what it is. You do a very broad gene testing. It's called whole exome sequencing or panel sequencing, where you look at a lot of genes at the same time, and then you can find variants in a gene you didn't expect. And that was the case in patients who had actually almost normal myelin, but very small central parts of the brain. And that, I think no one of us would have predicted that this would also be related to COLA3A. But that's that disease group. Yeah. So the question is about hearing loss in 4H. To be honest, I don't have so much experience on hearing loss in 4H. I've seen a few patients with that problem, but it's not the rule. So I think that's a question, a very good question also for the registry. So we hope to find more patients with it. I think should we move on?